everybody, the subcommittee is going to meet as soon as we can, so if you have business that's not related to subcommittee, I'd encourage you to take it into the hallway, and the subcommittee members will take their seats and we'll get started in about 3 minutes.
Wordsmithing?
Meeting will come to order. The first bill for us to consider is Delegate Farrell. Delegate, you have House Bill 1548. Please tell us the problem and how your bill fixes it.
Yes, sir, Mr. Chairman. This problem comes from the idea that it's sometimes difficult at certain places and at certain times to find an attending physician to say to somebody who has an advance directive, you are not capable of making your decision. So what this does is expands it to allow a licensed physician, a licensed clinical psychologist, a licensed physician assistant in the field of psychiatry, and a licensed nurse practitioner, to be able to also say this person's not capable. It expands the people that can say you need to be under the orders of your advance directive. It expands the scope of people who can do that.
So a person has an advance directive already.
Yes, sir.
Okay. And they are saying no, but the advance directive says yes. Correct. Everything. This is what we call the tie yourself to the mast, Ulysses.
Correct.
Okay.
It doesn't, yes, sir, Mr. Chairman, and I think that's important to reiterate. It does not change how a person goes about coming up with his advance directive or anything like that. It's the person who can say you have to be under the direction of your advance directive.
Okay. Now, what is the current, who can currently make it, who does this change it to?
I believe only currently Sarah, Council.
Mr. Chairman. We don't need you, but we do need Sarah.
I believe the current law only says the attending physician can make the call on the advance directive. And then, right, I believe that's currently the case. If you look up the on line 24, it talks about the attending physician certified writing. I think that's current law. It's only the attending physician. This expands the roles of people who can be there. Right now, it's just an attending physician. Now, I can say if there's a licensed nurse practitioner there, there's an attending physician or a clinical psychologist. It just expands the list of people, I can say.
Okay. Doug Farrell said this is a drafting question, so there must be something more going on, or would have just added four names to that spot. You got a paragraph, which means something else is happening.
I think I was trying to codify current practice about how it goes about it, but just putting in a code for the other folks as well.
Sarah? So obviously there's more than just that. That's what struck me. It's obviously if we just been adding 3 more people, we could have added that somewhere else and not had a paragraph. So the paragraph makes me concerned that
That's our friend in Charlottesville, Dr. Bonnie, can get a little draft that, Mr. Chairman. I think would be my answer.
Okay. On 1548, Delegate Farrell has said he wants to add some people to those who can make the determination besides the attending physician that someone's advance directive should take precedence over their currently stated desire, based on the fact they've been found to be, I forget the term of art, but currently incapable of making an informed decision. So the question is a paragraph here.
So, I'm sorry, I was out of the room just catching up a little bit. If we look at this, what the bill does is it does add to that list of individuals. Currently, only your physician or the
Attending physician.
or the licensed clinical psychologist can make that decision. So we're adding to the list of people who can make that decision. But also, if you look in C, C is different from B in that in sub C we're adding, we are speaking specifically to it's speaking to decisions regarding mental health care, including admission to the facility. So it's sort of it's differentiating that process from what we currently have in the law.
I think part of that was, Mr. Chairman, is we wanted it to be a little more frequent than perhaps the physician because, I mean.
I don't have any problem with the expanded list. I just want to make sure we know what we're doing. It should be obvious that we're doing okay.
The big thing is there, it does say in the bill, you have to recheck at least 180 days. It does say that. If you look at line 44, I believe, it says, it does specify the number of days they have to frequently go. That's also the bill.
Delegate Stumpy.
I'm sorry, I came just a little bit late. So has the person who we're making this evaluation on, are they currently been evaluated as competent to make healthcare decisions?
What we're saying is that we're expanding the list of people that can say, you're not competent to make your decision, so we're going to go by your advance directive. The person has to have an advance directive.
Delegate Stumpy, so back in the day, you had to make an advance directive saying the next time I decompensate, here's what I want to have happen. This is a complicated double lockbox procedure to make sure that you're with right mind when you make that. Now you're coming in, and the doctor's saying, directive says to give you X Resperdal. You're now screaming not to give me Resperdal. I need to decide what to do. And the idea was if you're now decided to be competent, then they go back to the advance directive that you executed before. And the question is, who makes that decision?
And we're not diluting somebody's advance directive. We're not diluting people's rights to make an advance directive. We're not touching anybody's ability to affect what's in their advance directive.
Sarah, coming back to my question though, what else does this do besides that, or that would have been 3 words?
Okay, so what this does is it clarifies in cases where we're dealing specifically with decisions regarding mental health care, including decisions regarding admission to a facility. In subsection C, that's what we're looking at. We lay out who may do it, and then the process there, made in writing, followed by an in-person examination by a person who's performed the examination prior to providing, continuing, pulling, or withdrawing health care. It's pulling out a subset of decisions there that we're talking about.
It says you have to put it in writing. It has to be done again every 180 days. And a lot of it's spent on designating who gets to do it.
other subset meaning we don't do these things? What other decisions are being made that don't have this thing?
I would say, and Sarah, correct me if I'm wrong, I think there may be a medical issue in the advance directive that you probably don't want you probably don't want a nurse practitioner in psychiatry making, as far as the person may have another condition, they may have diabetes, so that may be in their advance directive. This just speaks to say, look, we need to get this person now in a facility. The other medical issues in the advance directive would still fall under the old section where a physician has to make the medical decisions that don't have to do with mental health.
Okay, then, okay, I get it. So you're saying that the other stuff is for healthcare, not mental health. For mental health, we're gonna have a special set.
To get them in the facility, and then that gives people time to get a physician who can look at the advance directive and say, this person has diabetes.
Is it not, don't we need more changes then? Because isn't this now inconsistent with the previous paragraph? I mean,
So, are we talking?
I have a witness who would like to testify, I think.
let's just get, I just want to get the wording, so we understand what the wording is, and we'll take public comment.
So if you look at subsection B, this is talking about decisions providing, continuing, withdrawing health care pursuant
Trauma,
to.
stroke.
That's the broader healthcare. And then what we've done is establish the process specifically in subsection C for decisions regarding mental health care.
Don't we want to then say other than mental health care in B, just make sure that I mean, mental health care is a subset. I agree with Mr. Farrell, Dr. Farrell, that it's a subset, not a.
We do have the language, do have the language with the except as provided in subsection C, so that pulls that out as a special subset.
On line 20.
We can,
I'm happy to clarify if the chairman would like to.
I'm just trying to keep this simple. This is already very baroque language for the practitioners trying to. Okay. Okay. Any other member of the panel have any questions for the patron, or just sort of clarify what we're doing here? Delegate Hoagie, then Stowe.
Okay, I'm a little confused, and so what I'm trying to understand is, in my experience, an advance directive is where a person has said and made a decision prior to anything happening, a healthy person, that if ever they come to a point where they cannot make decisions on their own, they do not want to be on life support or anything that sustains their life. But this then is saying that if it's a mental health patient, that over their protest, that advance directive can still be instilled if they are protesting the decision to not sustain their life. That's what I don't understand. Are we creating something different for a mentally healthy person than for a mentally ill person, where a mentally healthy person may make a decision and say, no, that's not what I want to do. We're taking away any rights. My concern is in life or death situations for a mentally ill patient.
So I can help a little bit, and then I'll let you answer. But a few years ago, we recognized the problem that mental illness is often cyclical, and when someone is capable of making an informed decision, they might want to give us some directions for what happens the next time they're dragged into the emergency room and incapable. And so we set up a complicated procedure whereby you'd have to get two doctors sign off to say, right now, Ms. Pokey is of right mind and incapable of making a decision. She's going to do an advance directive right now. And then when you're brought into the hospital, they got to decide that when you're in the hospital, you're not capable. So what do? We're going to have to make a decision against your wishes anyway. Oh goodness, we have an advance directive. It was actually an effort to try to give people with mental illness some ability to guide doctors going forward. That's the setup. But it's very important when they're brought in to some decide you're not capable of making your decision, or else it would apply to everybody, and this would add to those people that could make the decision. That's the setup.
I think that is spot on, and I think what's important to know is that none of this occurs unless the person, when in a time of right mind, has agreed to this. So this advance directive doesn't even exist unless a person, when they're capable of making that decision, agrees to make it, to know what's going to happen if they're incapable.
Dr. Stalley.
Thank you. I think that's my concern in this, is so we've set up essentially a dual standard for developing competency or evaluating competency of an individual. And so if I walk into the emergency room and I do not have an advance directive, then I need to have a attending physician or a psychiatrist, psychologist make a determination on my ability to make a decision guess if I'm the CSB and I have an individual who I think is not competent, they can take and do that assessment, and they could get an ECO or a TDO to retain that person. I'm seeing the shaking of the head, but I think that we can, wherever this person presents.
Mr. Chairman, quite frankly, in the interest of time, I think it'd be helpful to have Dr. Bonnie here, and he couldn't make it this morning. I think it would be good to have him here next week. If it was all right, I'd love to take it by for the day. I know you don't like doing that usually, but I would appreciate it.
Now, we have someone who wants to testify.
I'd be happy with that.
I may not be able to come back in a week, or if you're going to be back in a week, it makes more sense to do it all at once.
I can do it all at once, or I can explain some of the questions.
I think we'll find that you'll have to repeat it anyway. If you weren't coming back,
Dr. Bonnie
you'll
will be
hear
here.
that's good. Okay, thank you.
Thank you, Mr. Chairman.
So we'll see you in a week.
That sounds good. That's fine.
Okay. Bye for the day. All right, next up. Who's next on our list? Chris, delegate head.
Thank you, Mr. Chairman. I have here for your consideration House Bill number 1435. This is another presentation of a requirement for drug testing for TANF participation and VU participation, so that we're able to see if we can get some assistance for those people in those programs that are using illegal drugs. As the committee has heard, and the full committee heard, all of the crisis that we have, particularly with opioids right now in the Commonwealth, we want to make sure that the people that are on drugs, if they're having a problem, we need to get them into a treatment program. And if you look at the way that this bill is set up, first of all, you'll notice that it is a screening process to determine if there's a likelihood that we needed to test somebody. And that's a program that would be fairly easy to implement. After that's done, then if there is a test, if they test positive for it, they would be ineligible for benefits unless they went into a drug treatment program. And that really is the intent of this, is let's get folks, if they're testing positive while they're on public assistance, let's get them into a program and get them the treatment so that we can get them off that. The whole purpose for these programs is to provide temporary assistance while they're being enabled to get back on their feet. And in this, if you're dealing with a substance abuse problem, then you're never going to get off the programs. And so that's what the purpose of this is for. I do recognize that there is fiscal impact, although I have to say this is the first time that I've seen a fiscal impact statement produced for this issue that gives what appears to be much more reasonable numbers in it. While it still is significant, it is going to need to be looked at. These numbers appear to be a lot more in line with what's reasonable, and as we're moving forward and take a look at this, there might be some benefits on the backside that we're not seeing as of yet. But that is the bill before you, and we appreciate your consideration.
Mr. Chairman.
Delegate, yes, ma'am.
Mr. Chairman, I have a quick question for the patron, just trying to get a bit of clarification. In the language, in section 1, I believe, it indicates that the screening process would require the local director of social services to screen each participant, but then it also goes on to say that a local representative of the department would administer the screening assessment. So I'm just trying to determine who exactly is making the determination in these cases. It doesn't seem clear.
Well, the fiscal impact statement goes into a little bit more detail of what the department believes would be the situation. First of all, the local department would utilize, as it says in there, the assumption is that they would use a commonly accepted screening tool such as the substance abuse subtle screening inventory to determine if there's a reason to require a drug test. It's estimated that tool would require 5 to 15 minutes to administer and 5 to 10 minutes to score for each one. That would be someone there. There is some training that would be required for that in the local area, but they're fairly straightforward and fairly common practice in other areas to utilize screens like this to indicate some sort of a red flag.
Follow-up question? I also wanted to get clarification. It indicates that after the initial screening, the assessment would then be periodically utilized, but not more frequently than 6 months. What's used to determine these periodical screenings in between after the initial assessment?
That would be at the discretion of the department when they set the policies.
And there, excuse me, Mr. Chairman, follow-up question.
Go
And
ahead.
so there's policy
You
that,
have the floor, go ahead.
oh, okay, so there's policy that would indicate how often they would or would not use these screenings?
That, and there again, that would have to be at the discretion of the department when they set up regulations promulgated out of this.
Thank you, Mr. Chairman.
Yes, ma'am. Anyone else have questions?
Mr. Chairman.
Yes, no, okay, let me, go ahead.
Permission to ask a series of questions.
You have the floor, go ahead.
Thank you. First of all, I received the subcommittee package today. I don't see the fiscal impact statement in my packet. So if I could please.
I don't have it either.
Could we get a copy of that fiscal impact statement? Because it appears to have been negligently or mistakenly not included in our package. I can ask other questions as well.
Go ahead, go ahead.
So,
Tell the gentleman it's online, I just pulled it up.
yeah, I'm just trying to ask my questions and if I get a cut. I'm old school, I like paper. So one of my questions is, for the patron, is you said that the purpose of this was to get people in drug screening. Is there a reason to single out welfare recipients as opposed to all people in Virginia to get them particularly in drug screening?
Well, Mr. Chairman, I would respond by saying, first of all, this is a program where this is state money, and we have a responsibility to be good stewards of the money that we are spending, and with the assistance that we're giving, we don't have that same responsibility per se to everyone in the Commonwealth that we would be screening and participating. And this is a way for us to, with this group of people, because they are getting taxpayer money, for us to be able to make sure that it's utilized in the most prudent manner.
Okay, so the goal is not to help the people per se, but to save money for the Commonwealth.
It is twofold.
So I've read a number of studies, and I don't know if the patron is aware of studies that show that the cost of drug screening is actually more than the cost of savings, that the fraud, that the level of people on these drugs is lower. By the time you screen everyone, the cost of screening actually costs the Commonwealth money rather than saving the Commonwealth money. And I would just ask if you've read those same studies.
I have read the same studies. I have also read some contradictory studies that take some other considerations into effect, which is why this issue keeps coming up again and again and again. And why it's also been implemented in a lot of states neighboring, and it continues to pop up every year with more states implementing some sort of a program like this.
And one more question, if I could. The TANF monies are traditionally used for an entire household. In other words, food stamps for kids. Is there a reason the gentleman can give me, if dad's on drugs, why dad's 5-year-old child should go hungry? How does the gentleman propose to resolve the fact that it's not the 5-year-old's fault if dad's on drugs?
If the gentleman would read the entire bill, you will see that it is only the portion of the benefits that would be for the individual that was testing positive, and that other family members' benefits would be unaffected by anything having to do with this. Because that would be a really bad policy and something that we need to address, and that's why it's specifically carved out in the legislation.
Thank you. No more questions.
Anyone else have any questions for the patron? Members of the public, this is an issue that's come up a couple times, and it sounds like we're sort of summarizing, that's why. Yes, sir, Delegate Hodges.
Thank you, Mr. Chairman. The patron mentioned long-term costs, for instance, incarceration, cost to the families with substance abuse, and the previous committee, and the full committee, and we had a presentation last week on the cost of substance abuse in the Commonwealth. I would just like to hear you elaborate on that a little bit, as far as the cost savings long-term.
Well, interestingly enough, as you're going forward in the fiscal impact statement, as I have seen, the long-term costs go up in the first year and then come down, and then there is nothing beyond 2020 shown as a cost on this. So I don't know that is entirely accurate. Maybe it's not being calculated out. But I think as you're moving forward, when you're dealing with people that are increasingly on illegal drugs or prescription drugs. And there's a problem with that. As we heard in our presentation to the full committee, the long-term costs of that from a lot of different areas are pretty profound. The more we can get into treatment, every bit of evidence shows that if you can get people into treatment, you overall long-term dramatically reduce the cost. And without treatment, people don't get off these drugs, period. Without treatment, it doesn't happen. With treatment, if we can get people into a treatment program, it has a much higher incidence of long-term success. And that's really what we want to get to. And also, again, being good stewards with our funds. And that's one of the legislation.
I'd just like to make an observation too, that this is not just about money. It's about the health of the family and the health of the person who has been screened. And the legislation says, and there is reason to believe, because from what you're saying, and it's true, the earlier that you get treatment, the more it is that you would have success in getting unaddicted to the drug. And so it is not up to Virginia if we suspect that someone has a chronic condition of addiction, that we continue to enable that condition to the detriment of the person and the family. And it's so important because we know what drug addiction does to families. I know personally because I had a son-in-law who had a drug problem. He's in prison now. He's my ex-son-in-law. But what it did to the family, and there was no way to compel him for screening in order to compel him into treatment. But if the state of Virginia is enabling, that's not what we want to do, and that's not our purpose for TANF. It's to assist families. It's temporary assistance for families. It's not for continuing enabling a drug addiction.
Okay, everybody, we would welcome any public comment at this time. So identify yourself and then tell us your thoughts on the bill.
Chairman Thomas Steinhaus with the Department of Social Services. The administration is opposed to this bill. Other states have implemented similar programs and found that there is really no problem. North Carolina found that non-recipients were 26 times more likely to have drug problems than recipients. Michigan did this in 3 counties. They tested 433 people, and they found 1 individual who tested positive. Other states have done this. Tennessee tested 16,000 people, 37 tested positive for a 2.3%, a 0.23% rate of testing positive. Missouri, 0.12%. Utah, 0.3%. Kansas, 0.39%. Mississippi, 0.05%. So I think this is going after a problem that really doesn't exist.
Thank you. Yes, ma'am. Are you also the videographer?
No, I'm not.
Oh, I'm sorry. I thought you walked over to the camera. That's fine. Okay.
No, I was just
Well,
standing there.
identify yourself and then
My
tell
name
us your
is
thoughts.
Catherine Pemberton, and I'm Director of Social Services in Powhatan County
Yes,
and
ma'am.
President of the Virginia League of Social Services Executives. The League has real concerns about this bill, mainly because our employment service program requires that we screen our TANF recipients for any barriers to employment, including substance abuse. We screen for learning disabilities, mental health disabilities, and alcohol and substance abuse within 90 days of the client signing the agreement of personal responsibility. Then the worker is obliged to refer them for appropriate services for whatever the barrier is. If the recipient doesn't follow through on the services, then the recipient can be sanctioned. So we already have a process in place, and I would echo Mr. Steinhauser's comments that this is not a huge problem among our TANF recipients. We acknowledge that substance abuse is a problem in our localities. It's just not centralized in our TANF recipients. Thank you for the opportunity to speak to you all.
Thank you, ma'am. Okay. Any other member of the public like to be heard in this measure? Yes, ma'am. Identify yourself and tell us your thoughts on the bill.
Good morning, Mr. Chairman, committee members. My name is Virginia Herr. I'm here with the Virginia Poverty Law Center. We would also echo the comments that have been stated by the Pope this morning, indicating that there is not appearing to be a significant problem with, as it specifically relates to TANF recipients supervision for probation and parole. So certainly, I think that would alleviate some of the concerns as far as that's concerned. Additionally, that case manager is responsible for reviewing the work placement and the work records of the individual. So certainly, if there was some concern about their work performance or impacting on their work performance, that case manager who is obligated to follow that new recipient would be able to indicate if any services or if they believe any services are needed based on the impact and work. As we stated, this bill has been before us on several different occasions, and at this point, families who are working hard to become self-sufficient need support and not suspicion. Thank you.
Thank you. Any other member of the public like to be heard on this measure? Any member of the panel like to be heard on this measure?
Mr. Speaker.
Yes, ma'am, Delegate Aaron.
I just want to appreciate the members of the public for the information that they provided, and I just want to make one final statement in that I think myself, along with my colleagues, we all agree that currently the Commonwealth is experiencing an epidemic as it relates to drugs, and we want to make sure we're very thoughtful about the approaches that we're taking to try and combat this issue. And in addition to that, I, as many of you, want to be responsible stewards of the state's money. So I believe we agree in that regard. However, I will say that this type of legislation specifically targets a select group of people, and it unintentionally allows representatives of the department to use a level of discretion that I feel is currently unclear as the legislation is proposed, and additionally allows imposed biases and stigmas to be used to target individuals in the way that is just inappropriate. I feel like if we want to utilize this screening method as a way to be beneficial to those recipients, then there is likely a way to do that, but this is not the way. And so I oppose the legislation, and I would move to lay the bill on the table.
Second.
Okay, there's been a motion made to table the bill, and that's been properly seconded. That is not a debatable motion, but another motion can be entertained. Okay, I'm going to ask to repeat. The motion has been made to table and properly seconded. That's not a debatable motion. A superior motion can be entertained. I don't have my chart in front of me. Let's table that. Everybody, there's a hierarchy of motions, and substitutions can only be made if they are superior, and I don't remember that list. It's been our first Okay, so actually, Move's report is not superior, so the motion to table must be taken up first. So, all in favor of the motion to table the bill, signify by saying aye.
Aye.
All opposed, nay. Nay. Opinion of the chair, the nays have it. Okay, the measure still stands before us. Is there a motion on the bill? Motion is from Major Report.
Mr. Chairman, I have a procedural question on the move to report.
Yes, sir.
Given that there is a fiscal impact, wouldn't it be a motion to report and refer to the ninth floor to appropriate funds?
Let me ask the patron, I think he's right. This does have a FIS, right? Okay, so I would ask the person who made the motion report to bring it back. Okay, the motion of the report has been, take it back, whatever the term is. All right, the measure stands before us. Is there a motion to report refer? The motion has been made and properly seconded to report refer the measure. This would bring it before the full committee. All in favor of the motion to report refer, signify by saying aye. Aye. Opposed?
Nay.
Okay. So, nays, raise your hand just so that staff has. Nays on the report and refer.
Yeah, nay. Nay on the report refer.
We are voting on the report and refer. Nays, raise your hand. Okay. Reports and refers 4-3. Okay.
adopt an amendment that this bill passed the Senate with this amendment, so if we go ahead and look at that. Distribute that, please.
So, Sarah, would you report the amendment delegate would like us to include? David, you would report the amendment the delegate would like us to include, or is it a sub? No, Mr. Chair, it's a sub. Staff distributed the sub, and I assume the amendment is included herein or no?
Correct, Mr. Chair.
Okay, so the sub includes everything we need.
I appreciate you adopting.
Is there a motion to adopt the substitute? Is there a second? All right, all in favor, signify by saying aye. Aye. Okay, and it's, for the audience, it is our general policy that the patron gets to put the bill, whatever shape he wants, before we take it up. Okay. All right, so. So delegate. Here we go. All right, so this is, the key is to make sure that the lawyers don't yell at you and say that you're a lawyer. Is that done? Okay. Delegate Pope.
Is this creating a new definition or new initiator in this qualified advanced director facilitator? Is that something that has not been in the code, or is this a new definition in the code?
Mr. Chairman, yes, this is a new definition in the code, and the definition of qualified advanced director facilitator essentially would require an individual to complete one of a series of approved training programs for advanced director facilitators. The examples available today include the Honoring Choices program, which is sponsored by the Richmond Academy of Medicine. There are a couple of other similar programs in the state. This essentially recognizes those existing training programs. And each of these programs follows the what is it is considered the standard, which is the respective choices model for advanced director facilitation.
I have some questions. I don't want to. Anybody else have any questions for the patron? Okay, Delegate Pogge, until you're finished. Go ahead.
How would a person be recognized to need the assistance of a qualified advanced director facilitator? Would that be through his primary care physician, or if he is in the hospital? How would this new position come into effect to be able to minister to a person who needs help understanding or filling out an advanced directive? Where would the progression start for that?
Mr. Chairman, currently today, again, this doesn't change anything for healthcare providers today. So many times when you're within a healthcare institution today, there are resources within that health, either health system or whether it's a physician's office or others that can direct you to a clinical social worker or other individual that's qualified to complete these under the definition of healthcare provider. With respect to the qualified advanced director facilitator, that would be up to the individuals that are employing or organizing volunteers to provide those services. You have many groups throughout the state who are very interested in having greater availability of advanced directives, and so those organizations, private, nonprofit, and other organizations, it would be up to them to advertise the availability of these qualified advanced director facilitator services.
Is there going to be, or could there be mandates on health providers to sort of sort and try to direct them to find people who need these facilitators? When someone comes in, they're sick or have a chronic illness, are they going to be referred to a facilitator?
Mr. Chairman, in response to that question, currently today in hospitals, for example, on admission, hospitals are required as part of their conditions of participation with Medicare to provide information about advanced directives, and that is a common practice in healthcare settings, especially in the inpatient side, providing information about advanced directives and refer them to individuals within the health system to receive those services. So that's something that's in place today. Again, this bill does not change anything for healthcare providers today. That is in place, and those sorts of practices in terms of helping to promote greater use of advanced directives and healthcare providers are already in place. This just would allow it to occur in other settings, social
I've done these. Okay, let's start with the top. Advanced medical directives are great. They let people sort of ahead of time when they're thinking clearly, try to figure out what they want to do. The issues are very, very big. Do you want me to cut off the water? Do you want me to cut off the food? I mean, that's what goes into advanced medical directive. I don't think being a lawyer has any particular competence. I've done them, but they're not, law school didn't help me with this. My concern would be who are we visualizing is going to do this? Because if the person doesn't walk the person through some of these hard choices, you're not really getting the whole point of this, which is some advanced thought about how I want to handle these difficult life-ending moments. I mean, when it was a doctor, I felt pretty good about it. Even nurses felt pretty good about it. If it's going to be the receptionist who, in the middle of taking phone calls and shuffling stuff, sort of says yes, yes, no, no, and it's done, that's probably not what we're looking for.
I'll take a stab at it because you're spot on. This is where I work. If you have an advanced directive, the family doesn't have to make a decision. What this allows us to do is expand with proper training. The folks who are able and qualified to sit down and talk through that with people at a time when they're rational and it's the right time to have that discussion. It does not change anything that the healthcare world's doing now. It's just an add-on. This is an effort of organized medicine. Richmond Academy and various societies feel strongly that, just like we said, this is the very best you can do with somebody in a life situation. So that's kind of what we're doing.
Right, and so I mean, getting to what the bill does, if it said, it had a list like we sometimes have, doctor, nurse, social worker, and again, I'm not sure those have special competence, but I'm just looking for somebody. This class has got to be a 6-hour class. I mean, it can't be a 4-year program, or else no one will take it. So I'm visualizing that they set up a program and they send people over, and I just don't want to divert this so low that it goes in my office from me to the paralegal to somebody passing and in the hallway hands you something, you check some boxes, and I prepare the document, and suddenly that's going to decide your life. Do we have any notion of who's going to take it? In other words, I don't want to pick on receptionists. I'm just thinking of them as somebody who's very busy and has got a lot going on, so they're not the person I want to try to focus on.
Yes, Mr. Chairman. Just one point I will make. You alluded to earlier that an attorney doesn't have the magical skills necessarily to complete these. Some, with a physician or a nurse, for example, you certainly understand healthcare decisions in a different way, in a clinical way. But I will mention that these existing programs that are identified here in the amended language, in the enactment clause, these are recognized programs that are even attended and used to help train healthcare providers as well. Not every physician approaches the issue the same way, and so these programs are extensive programs. They have a series of communications that they acknowledge that would be appropriate, required for patients to consider. So it is intended and designed to train an individual how to facilitate those conversations and create a uniform approach to how these are done. And so the suggestion is that these recognized training programs, again, the respect and choices model that these all follow is sort of the gold standard for training an individual how to
I'm asking.
I'm sorry, too. Also, Mr. Chairman, in terms of who do we think would be doing this sort of thing, presumably it would be social workers, geriatricians, and others that are, again, working in existing agencies that interface with individuals in the public. It might be individuals that are working within legal aid clinics that are attorneys, other individuals like that, organizations that are currently helping to connect people with these resources.
I'm not asking the question very well because you're very informed and smart and trying to help, and I'm not getting any information. Are you visualizing? I mean, what I'm thinking of is there's a group of people in some training. Because first off, how much training are we talking? 120 hours or 6?
I don't know off the top of my head.
And I don't either, but I'm assuming, and what I'm thinking of, if we're thinking social workers, that's great. If it's this, again, the social worker hands it off, and before you know it, the only safety net we have is this, the CLE style training. That's what I'm trying to visualize who we think is actually helping. I want to get as many of these as we possibly can. I hope everybody has one. I just wanted to sit down with you and say, now, Doc, understand this little checkbox you're about to do. is gonna shorten your life by 6 weeks, because this is where we take, and that's great, or not. But this is a decision we want you to make, understanding that when we say, I forget the terminology, but when we remove you from hydration, what's hydration mean? Well, that means when we stop giving you water. And what I'm getting is, I just want that conversation to take place, and they go, yeah, please, or absolutely not, but that they know that. And I just want to, I mean, is there, if we're saying social workers, let's say social workers. If we want to say geriatricians, let's say geriatricians. If there's something else in the code we can grab, let's do that. Or some more information about this training program, so we know that it's not a 3-hour, do it in an afternoon while you're thinking about your shopping list. If that's the safety net, we need to have some more information on the safety net, that's all.
Well, I will say that the enactment clause defines current programs as they exist, and it does look back to the department to go ahead and work with the stakeholder or the other DARs, DBHDS, and the BAR to determine which programs will be adequate. So I think there are some things. If you want to wait,
I'd rather move. I mean, is the Department of Health here? If we're,
Mr. Chairman?
because if they're the ones who are going to set up the regs are fine. No, we don't need to get down into committee meetings. I just want to make sure before we start saying, yes, sir. Mr. Delegate Stolly, and then we'll take public comment. Go ahead.
I've just been involved in a number of these training. I would caution against certifying or specifying a certain level of training to be done, because this really is a team approach to how we do this and working within the office. I think that the training programs that are listed in this bill are very good training programs that prepare somebody for walking through the steps of an advanced directive, whether that's the post directive or one of the other advanced directives that we use. And I think that you say, well, it has to be an LPN, it has to be a licensed clinical social worker. We are actually restricting access to be able to do this. These are good training programs that prepare people very well for sitting down and having these conversations. And I would be concerned if we start saying it has to be a licensed or a registered practitioner, that we're going to actually limit access to this.
Can somebody tell us about the program then? If the program is the protection against.
Mr. Chairman, I don't have specific detail with me today in terms of the different modules included in the program or aspects of those programs, other than just repeat that it's been generally recognized as the standard for these training programs.
So do you have any? This is that we're basically giving a stamp of approval saying this, someone's gone through this program is capable of advising someone on life and death decisions. I would just feel a little safer if I'd have.
Mr. Chairman, Joe Hilbert with the Health Department. We worked closely with Mr. Rawlings and other stakeholders, Delegate O'Bannon, on the substitute language just before you. Everything we've been told by the stakeholders and that we understand is that the programs that are listed in that second enactment clause are universally accepted as has been said, the gold standard. So we would be, as we've told Delegate O'Bannon, we're comfortable with the language as it exists in terms of being able to move forward.
All right, Delegate Pogge.
Is this a practice that's like already being implemented? Because I was under the impression that traditionally it was something that a patient discussed with their physician and their family members. But so what I'm wondering is this, do we need something like this to help save time for physicians? I know they're under the gun and can only see patients for a certain amount of time. Is this something to relieve that responsibility from physicians by bringing in a third party? Because I think this is something, and maybe I'm wrong, that physicians generally did with their patients.
Delegate Pogge, my understanding is this bill is all about trying to increase the amount, has been said, increase the use of advanced directives, and that's really the intent of the bill. And the second enactment clause identifies a series of programs that, should individuals complete those programs, that would provide an additional means of people to work with patients in the healthcare setting and elsewhere to have the advanced directives put in place.
Mr. Chair.
say that although healthcare providers are trained and can do this now, it's a chaotic world out there. Physicians, nurses, they're busy taking care of patients, and it's time consuming to sit down with an individual to do these advanced directives. So we're giving tools to individuals, training them to work with these patients, to make those decisions, and also in the training process, if they need to discuss it. When I had a joint resolution last year in these programs, these trained individuals know when to refer those individuals to the physician for those questions, and to have that discussion with the physician at the appropriate time, and that is actually part of the training.
Mr. Chairman, if I just might add on to a couple of the questions that have been asked. I want to clarify the impetus behind this in the first place was the issue of the unlicensed practice of law. And, there is an Attorney General opinion that basically suggests that anyone other than a healthcare provider that is facilitating the completion of advanced directive violates the unlicensed practice of law. And these opinions also recognize that in order for that to not be the case under the court rules, there would have to be some exception under law. And so we're recognizing the unlicensed practice of law issue and answering the question of if it's not an attorney, then whom? And this is the next. We already know that healthcare providers are recognized under the law, and this just it establishes, because what the concern is that there are individuals out there that are facilitating and are inadvertently violating that unlicensed practice of law. And this just answers that unanswered question. And it's been, within the advanced directive sort of bar in the state. And I also forgot to mention the Virginia Bar Association is supportive of this bill, carrying this bill. It's on their legislative agenda this year. And so this is more about the advanced practice license. It's not intended to alleviate or remove anything from the healthcare providers' workload. That is something they will continue to do and want to continue to do. This is talking about what happens outside of those healthcare institutions and making it available in a different way without the unlicensed practice law. We do not want to do any changes to what's going on in healthcare settings currently.
So, I'm sorry, I don't want to. So the issue about having the Department of Health do approval, so we can, I think, legitimately say we're not going to get down to the weeds like Dr. Stolly said, but we'll let them approve. The problem is this bill doesn't do that. This bill says we hereby deem approved. I mean, they actually can't. Even if the Department of Health said they're terrible, we've done no more work, and it's a diploma bell for $60 that they do a lousy job. If you can't, I make a suggestion. If you can't tell us enough about it for us to figure it out, I'm comfortable letting the Department of Health make those decisions for part-time. But we then need to change this from shall to may. And what I mean is, look, these are ones that you may approve or something. But somebody's got to look at these programs in enough detail to say these are the ones that we're going to cede this power to. Now, I'm open either way. It would be very simple. Following programs are deemed to be approved. To change that to after review, the following programs may be approved, and would indicate to the department that we think they're good and we want them to do it, but they could at least veto it if they decide that we're lousy. Or we really need to, I think, have them come in and explain why the program. I mean, if we're saying these are programs that hereby are authorized, what would be simpler than this step?
I know.
It sounds like everybody's working together. I just don't. If you're saying the department's deciding, the department's saying we're deciding, and nobody's reviewed the programs except the.
Well, I think these programs are already well respected.
Well, and they may be great. I just want somebody to look at them.
I just want the department to be able to have the veto power over.
Yeah, right. This as written. This would say we hereby, as the General Assembly, say you got to take them. Any reason why we couldn't do that?
I'm not proposing that.
Okay, so Sarah, what I'm suggesting would be, and I don't have the language, but it'd be the following training programs. They say are deemed to be approved, and I'm just saying could say may be approved by the Department of Health as training programs. That would be pretty simple, and then that would get us out of this box and let them. Does everybody understand what I'm suggesting? It's just, yes, sir.
As new programs
Yeah, they wouldn't foreclose anybody else and just say.
Well, as new programs, come about, they would then have to be added in this code section with that language, correct?
Well, this is not, because this is an enactment clause, it will never appear in the code. This is just some initial, when we pass a bill with an enactment language, it kind of goes out, but it doesn't end up in the code books. But there'd be no reason we couldn't say, Mr. Chairman? Oh, delegate, yes, sir.
maybe this addresses your concern. Maybe we should simply say that training programs must be approved by the Department of Health, and then you have the oversight that you're looking for.
That's what I want, but I don't mind us listing these first few as a, hey, go look at these. Enactment clauses are used for that kind of stuff all the time, so that's a,
What I'm saying is, I don't think in the bill it says that training programs have to be approved by the Department of Health, or am I missing something?
you are, on line 142, it says Department of Health shall approve a program for training, so.
A program,
Mr. Chairman?
not all the programs.
Right, no, I mean, they can go through and they shall approve a program or not. What I'm saying would be, it's the enactment clause that says then, we hereby deem the following as approved.
I said, Mr. Chairman, my question is this. It says the Department of Health approves a program. Everyone knows that program is good. What it doesn't say is the Department of Health has oversight over these
Just a
other.
sec. Let him finish, then I'll go to you. Yes, sir.
It says the Department of Health approves a program, that's good. What I'm saying is it doesn't say the Department of Health has oversight over these other programs, these alternative programs, these diploma mills that you were concerned about. And I'm just saying, if you simply say that all programs must be approved by the Department of Health, not just a program, but all programs, I hope that will alleviate your concern.
I don't know that we need to change the language. Dr. Bennett?
I would refer the committee to line 84 in the substitute.
Okay, so.
Okay.
That's how I'm just, Delegate Manley, we've got a couple of options in front of you. I'm perfectly comfortable moving this forward today. If we could just say the department will be the ones who decide what programs, and I like what Delegate Hodges is saying, that 5 years from now, one of these will be gone and a new one will come out.
So I think with line 84, if you want to change the enactment language on 151 to a may, I think that would be
So Sarah,
fine.
could you read us what you would use your legalized language to say?
Mr. Chair, the amendment would be on page 6, line 151, after programs, strike are deemed to be, insert may be.
Okay.
And the second amendment would be on the same line, after approved, insert by the Department of Health.
Okay. And do we need to make any changes to address the issue raised by Delegate Hodges that we would want to have room for more? There's no reason not to. I mean, it's an enactment clause. Well, actually, we got a final line. It says, and any training program that follows their respective choices advanced care planning model for facilitator certification. So I think it's covered. Okay. I'll make the motion. I will move the amendments described by staff with regards to line 151. Is there a second?
Second.
All in favor signify by saying aye. Aye. Opposed. Okay. Any member of the public like to be heard on this measure that hasn't already spoken or has already spoken wants to speak on something new? Respondent, please come up. Identify yourself. Tell us your thoughts on the bill.
Hi, I'm Bonnie Neighbor and formerly with Vogel, the State Mental Health Consumer Organization. I've been trained as one of these certified facilitators and I've helped write one of the training programs, but I haven't seen the language to see if it's one of them that's included, but since I worked with Dr. Bonnie, I'm assuming that it probably is. I was included in the training, writing a training because of my expertise in the mental health area. And I know, as a trained person, that when somebody asks me what's the difference between removing hydration and removing food, I know the answer is if you remove food, I'll probably sleep a little bit more and eventually sleep and die. And if you remove hydration, I'll probably go into kidney failure and it'll be painful and I'll die. But I'm not going to tell that to people because I'm not a doctor. So my role as a facilitator would be, gosh, on that question, you really need to talk to your doctor about the alternatives. I can speak a little bit more to the psychiatric things. That's how, in the courses I've seen, facilitators are trained. To not give advice, but to say, if you have questions on this, further questions, here's an expert you can talk to, here's an expert you can talk to. That helps alleviate any concerns. I heard the question about, is the problem that the doctors don't have time or the lawyers don't have time? And I think that it's bigger than that. I think that across the state, there are people who may want to fill out an advance directive, but who have some challenges reading the options and understanding all the implications of that. And they may not want to spend that precious doctor time, when you only maybe get 15 minutes, talking about the legal language in the advance directive. So is there someone there who can help them understand that language? It just increases the choice of who can do that. I'm trained and certified, but I can't help someone because I don't have a connection to a doctor's office. office or a lawyer's office, so I'd be practicing law without a license. One last thing is I believe, and I could be wrong, but I believe Virginia, we don't have to do what other states do, but I believe Virginia is the only state that sees this as unlicensed practice of law, that other states allow people to help facilitate, and so I completely support this. Thank you for bringing it forward.
Thank you. Any other member of the public like to be heard? And if you're for it, I think it's in good shape, so go ahead.
We'd like to express our support to, this would really support the work of our organization and allow us to broaden access to advanced directives.
Tell us who you are.
I'm so sorry, I'm Melissa Gibson with the Disability Law Center of Virginia. Thank you, Mr. Chairman.
Thank you. Yes, sir.
Davis Creek with the Virginia Poverty Law Center. We support this bill.
Thank you.
Mr. Chairman, members of the subcommittee, Ralston King with the Medical Society of Virginia, we support this legislation.
Mr. Chairman, members of the subcommittee, Matt Mansell, Virginia Healthcare Association, and Virginia Center for Assisted Living, we also support this legislation.
Mr. Chairman, Jeff Palmore with Reed Smith on behalf of the Virginia Bar Association, and we support the legislation. Thank you.
Lawyers and doctors, cats and dogs. All right. Any other member of the public like to be heard? All right, motion made to report and seconded. Any further motions? All in favor signify by saying aye. Aye. Opposed? Excellent.
I want to really thank the chairman of the committee, I appreciate it.
Oh, no, thank you. Okay, so we have Delegate Tyler, then Delegate Dickey Bell, and then a couple of committee members. So, Delegate Tyler, welcome.
Thank you, Mr. Chair. I am before you for House Bill 1615, and this bill is introduced at the request of the Virginia Department of Health Office of Chief Medical Examiners. And basically it's before you because over the last 10 to 15 years, the Office of Medical Examiner have encountered problems with the number of physicians who are willing to serve their communities as local examiners. At one time, there were about 300 physicians serving as medical examiners, but today there are approximately 80 active medical examiners. As a result of this situation, communication back to the Office of the Medical Examiner for a timely notice of death, completed documents or investigations, toxology samples for further study is neither timely or complete. This bill is before you to clarify the authority of the Chief Medical Examiner and the length of service of each medical examiner. The bill simply says that the Chief Medical Examiner can, in current law it says shall, but basically this says may, appoint medical examiner for each county and city. Secondly, it clarifies that local medical examiners will be assigned cases to investigate by the Office of Chief Medical Examiner staff. And thirdly, the bill describes local medical examiners' appointment, which will begin on the first day of October, and the term of each medical examiner shall be 3 years. It simply is a bill to clarify the authority of the Chief Medical Examiner and the length of service. I have before me, with me this morning, Dr. William Gormley, Chief Medical Examiner from the Department of Health, to speak to the bill at the appropriate time.
So now is the appropriate time if you'll have to come up. Dr. Warren. So reading changes the shall to a may, I'm not sure the impact that would have, so.
The shall says that I will appoint a medical examiner for each jurisdiction. Since there are only finite number of medical examiners or less than that, there's no way I can appoint a medical examiner for each position, because local medical examiners are volunteers that do the community service. They get a small fee per case, and the fee doesn't cover the time that they do it, that they take away from their practice to do that. So since I can't do I can't appoint a local medical examiner, I don't have volunteers for that. It's better to just have May. So
you're breaking the
so
law.
I'm not breaking.
You'd rather not break the law.
I need to find other laws to break.
So tell us the local obvious, and maybe even then, and somehow somebody needs to pronounce cause of death. Is that, do we have it basically right, or is that not even the?
Well, close, very close. When death occurs in the community, and it's recognized, if somebody feels like the death may be a medical center case, it needs to be reported to the medical center. There's no law that says every death has to be reported to the medical center's office. But typically, deaths at home, certainly violent deaths, deaths that are due to clear accidents, homicides, things like that, or they're questionable deaths. Those deaths are reported to, formerly, the way the law reads now that we're trying to change, those deaths are reported to the medical center. That could be either a district office or the local medical examiners. Originally, back in 1947, when we were established, the local medical examiners handled the whole thing. The deaths reported to the medical examiner with the name of the person that died, when it was, and what the circumstances were surrounding that death. Medical examiner or office has to determine, firstly, does that fall under the jurisdiction of the medical examiner? Because the medical examiner says, okay, we're going to investigate this death, and we're going to take authority from the family and disposition of remains for a while. So that's an important thing. We have to have be legitimately doing that. If the case falls under the medical examiner's jurisdiction, then you have to determine how is that case managed. And the management of a case can either be, if we can determine the cause and manner of death and collect any evidence that needs to be by just doing an external examination and collecting some toxicology specimens, then that can be handled by a local medical examiner in the community. The body doesn't have to leave, doesn't have to be transported. It's less expense, less disruption for everyone. And that's the job of the local medical examiner. Also, in some cases, the local medical examiner may need to represent us to go to a scene to help understand what's going on. If the body requires a full autopsy examination, then it's transported to one of the 4 district offices for that examination. And making those determinations is part of the process. Originally, the local medical examiner would take those calls, make a decision, and if they get a local examination, we would find that the district office would get paperwork documenting that within 30 days, which is a long time nowadays. Current standards are that for certification by the National Association of Medical Examiners requires our forensic pathologists to review each report, the deposition of those reports within 24 hours of the case that we made.
I find this more interesting probably than some of my colleagues do. The specific, this is about the local guys though, right?
Well, this is the findings that over time, more of the death reports and most of our death reports are being made to the district office.
That's the question. The places that don't have, you said we don't have enough to fill, they're being made by some in your shop.
Right, so we're taking more and more in the district office, more of those calls. We now have full-time investigators that answer the phone 24/7. They can make decisions unless there's a question. They consult with the pathologist if there's a question. So we've evolved to a system where the district offices take the calls, make that decision, and then when there's actual work to be done for the local medical examiners, they call the local medical examiner and say, hey, we have this and such a case, and could you do a scene, which is different than the way the law is actually written.
Let me so what I guess what I'm getting at would be, we have for many, many years had the local MEs where we can. I don't hear that this is an effort to get rid of that,
No.
but I understand it, times have changed and you can't do it where.
This is an effort to, one, use them more efficiently. Well, we have, there are about between 1,300 and 1,400 deaths reported to our office each year. Of those deaths,
else have any questions for the patron or the gentleman, the doctor? Any member of the public like to be heard on this measure? What is our pleasure? Motion be made and seconded to report. All in favor signify by saying aye. Aye. Opposed? Thank you, Delegate.
Thank you.
All right, I have Delegate Vicky Bell, and then if they're available, Delegate Price, Delegate Garrett, and if not, Delegate Robinson. All right, Delegate Bell. Thank you, Mr. Chairman. Tell us what your bill does.
First of all, there is a substitute.
Ask staff to distribute this out. Is there a motion that we adopt the substitute? All right, all in favor signify by saying aye. Aye. Opposed? Okay.
And Mr. Chairman, there is one line amendment to the substitute.
Ask staff to report the line amendment, please.
Mr. Chair, the line amendment's going to be on.
Wait. Let them, they don't have this up yet. All right, yes, sir, please go ahead.
Mr. Chair, the line amendment's going to be on page 2, line 26, after conditions of participation, insert as. It's technical.
Okay, all in favor signify by saying aye. Aye. Opposed? Okay, so, Delegate Bell, tell us about the bill.
Mr. Chairman, this legislation requires the Board of Medicine to amend regulations regarding continuing competency of occupational therapists to define type 1 continuing competency activities. It prevents the Board of Medicine from deeming maintenance of any organization's certification as fulfilling continuing competency requirements. The current regulation defines type 1 continuing competency activities as, quote, activities offered by a sponsor or organization recognized by the profession and may include in-service training, self-study courses, continuing education courses, specialty certification, or professional workshops. The problem is it's unclear to practitioners what organizations recognized by the profession means exactly. This legislation fixes that by spelling out all qualified organizations. And additionally, the Board of Medicine is currently trying to give one organization regulatory preference over all others by deeming maintenance of its certification sufficient to fulfilling competency requirements. The legislation prevents the Board of Medicine from giving that preference to any one organization or another, or in other words, from picking winners and losers.
Okay. I think I understand every word you used, but I'm not sure I understand enough of the context that we put together. So, if I'm an occupational therapist, I need to have some kind of maintenance training, lawyers we call CLE requirements, or something you have to do to keep your license. Is that right?
That's correct.
Okay. And OTs, they're governed by the Board of Medicine.
I'm sorry.
The occupational therapists are governed by the Board of Medicine. They're the ones who oversee. Okay. And so you need, what, 40 hours, 20 hours, some amount of time? You're welcome to have somebody with you.
Mr. Chairman?
Yes, sir.
Hunter Jamerson, Virginia Occupational Therapy Association.
Yes, sir.
In Virginia, the Board of Medicine's current standard for OT continuing education is maintenance of 20 continuing education hours on a biannual basis.
Okay, so every 2 years you need to have 20 hours of, okay. And the question is, with whom you can take the class?
So, Mr. Chairman, there are two questions in the bill. One is what the class would have to constitute. The second is who would have to offer it.
Okay. So, and this would list, it says a list of groups that can.
Yes, sir. And speaking of the bill, Mr. Chairman, so the bill is before you in the substitute. preference among those various accredited agencies.
Okay, so let's go to the first. It looks like a pretty open-ended association. It's community college, federal agency, state, local, healthcare organization accredited, so it's a pretty broad, those are the ones that are okay.
It is, Mr. Chairman, and I'll add that this language tracks exactly the existing regulation of physical therapy, so we've modeled this off of existing regulation.
Okay. And then, but I don't understand the second part. So there's then, so those are the list of things that are okay. What's the second paragraph do?
The second section of the bill, Mr. Chairman, addresses a pending regulation of the Board of Medicine, where the board has proposed to create a preference in its regulation for maintenance of certification by the National Board for Certification in Occupational Therapy. So in the profession, there are certifying bodies that help you present yourself, hold yourself out as meeting a higher standard than some of your peers, and they offer certain certifications if you meet their standards. The board has proposed a regulation to say, if you meet NBCOT certification standards, then the Board of Medicine in Virginia shall deem you to have met the Board of Medicine's continuing education standards.
Okay, I see. So when it says shall not deem, what you're saying is, you just, I think I got it. Okay, any other member of the panel have any questions for the patron of the bill?
Mr. Chairman.
Delegate Stowick. Yes, sir.
Just a quick question. So tomorrow I can go out and set up the Quistelli certification board and issue a certification. Who regulates? It sounds like the Board of Medicine is currently the one regulating acceptable boards. If we put this piece of legislation in, does that take the authority away from the Board of Medicine, or are we saying that the Board of Medicine continues to have this authority, but they must at least recognize these folks?
Dr. Stanley, Mr. Chairman, presently the board's regulation authorizes all entities recognized by the profession, which is a very unclear standard. Under the proposed Section 1 bill here, the regulation will be amended to spell out all of those entities with whom we are aware the board is presently accepting continuing education and setting a standard of accreditation as recognized generally as being sufficient to offer Type 1 education.
Mr. Chairman.
Delegate Stowick.
So that so the board still decides who is recognized to do the Type 1, or who recognizes that this is an entity that can provide that moving forward?
Mr. Chairman, Dr. Stanley, my interpretation of Section 1 of the bill would be that the board would retain the authority to determine who meets these regulatory standards, and the regulatory standards would spell out the accreditation required to offer Type 1 training.
Thank you. Anyone else have questions for the patron or member of the public like to hear this bill? Dr. Brown. Identify yourself, tell us your thoughts.
Sure. David Brown, I'm the Director of the Department of Health Professions. Board of Medicine is under my department, and as is the Advisory Board on Occupational Therapy, which is the board that directly does this. I just want to offer a few comments. One is the advisory boards and the board, like the Board of Medicine and the Board of Nursing, typically are who look at the details of what things should be in the requirements for licensure and licensure. And I think that, so I would personally have some concern that this is raising a fairly intricate set of requirements to the legislative level, and perhaps it should be left to the state level, to the regulatory level. Secondly, there is a proposed regulation, and as you've heard, that this bill in some ways is a response to. But I should point out, it's a proposed regulation. It's currently under review in the Secretary's office. If the Secretary and the Governor approve the proposed regulation, it would then go back to the Board of Medicine, initially to the Advisory Board of Occupational Therapy, for a 60-day comment period, including a public hearing. So concerns about the content of the proposed regulation, we're not even halfway through the process. After that public hearing on the current proposed regulation, the Advisory Board on Occupational Therapy and the Board of Medicine could adopt that regulation, could amend that regulation. They could withdraw that Secondly, when it comes to the details of what you've been listening to, which I actually find fairly complicated, you should know that currently MBCOT, the National Board of Certification of Occupational Therapy, is a requirement for initial licensure. So what the proposed regulation, that you really don't have in front of you, the proposed regulation does says, if you maintain that certification, we'll accept that for continuing ed. So in some ways, what I think the advisory board and the Board of Medicine are trying to do is simplify life for their licensees. However, it doesn't require you to maintain that certification. You can still just go through the process that we currently have in place without keeping up that certification. Secondly, it doesn't specify, secondly, the certification for the MBCOT, people can include coursework from the American Occupational Therapy Association, Virginia Occupational Therapy Association. So it doesn't create an exclusivity. It just, in some ways, simplifies life for those occupational therapists who are maintaining this advanced level of training to be able to very simply maintain their licensure. And I'd be happy to answer any questions about the process or, as best I can, the content of the proposed regulation.
Mr. Chairman. Delegate Hodges.
Thank you, Mr. Chairman. Recommendation for the legislation, did that come from the advisory board? The recommendations in this legislation?
No, it did not. I'll let Mr. Jameson comment on that. Let me just say this, Mr. Chairman. This is the first I've heard from Dr. Brown or anyone associated. It's our understanding that the administration did not take a position on this bill.
Mr. Chairman, Delegate Hodges, Virginia Occupational Therapy Association requested Delegate Bell put in this bill. The proposed regulation before the board was inspired by a request from the National Board of Certification in Occupational Therapy, who would receive the preference under the proposed regulation.
Thank you. Okay. We have given this a full hearing. Any other members of the public like to be heard? Yes, ma'am. Identify yourself. Tell us your thoughts on the bill.
Good morning. My name is Dr. Diane Simons, and I'm an occupational therapist. I've been an OT for over 30 years, and I've been a professor of occupational therapy for the last 20 years. I'm here today representing the Virginia Occupational Therapy Association, which represents about 600 members of the state that are in the active in the professional association. As you heard, this bill is really just to clarify the ambiguity by listing out those organizations that are indeed recognized by the profession, separates those from those that are not. I've spoken at length with our continuing education chair of the professional organization, and she approves vendors or providers that want to come into the state and provide continuing education to our membership. She says she regularly has to reject proposals because they're subpar, they lack evidence-based practice, they don't have measurable objectives, they're not current with current occupational therapy language as approved by the American Occupational Therapy Association, and there are insufficient presenter qualifications. So we clearly have people that are trying to come into the state that to offer continuing education that is not acceptable. So this bill would be more specific in terms of identifying those organizations that are recognized by the profession. And in addition, it does prevent the state from delegating responsibilities that have been given to them as the licensees of the profession over to a national credentialing agency. So the VOTA board voted unanimously to try to pursue legislation in light of what had gone forward with the OT advisory board.
Delegate Roberts.
A comment, because I know under the Board of Medicine, the ranks are a little different than you are under the Board of Medicine. But under the Board of Optometry, there we have a laundry list of specific organizations that are approved continuing education courses in our regs. So this is not precedent-setting legislation because it's already in optometry regs.
Yeah, exactly. This language was taken directly from the regulation of
26. This is an effort that's coming from the Deeds Commission, from the subcommittee or task force that I chair on crisis response and emergency services. And Mr. Chairman and Delegate Ghost, I appreciate your work and on this effort as well. This deals with that emergent time period in which someone is identified and needs to be transported as part of the emergency custody or the involuntary admission process. This is a Section 1 bill that will direct the Commissioner of DBHDS and the Director of Criminal Justice Services in conjunction with a long list of other stakeholders. And I believe there is a bit of a technical change. Senator Barker has this bill on the Senate side, and the name of one of these folks has changed. David, do you have that?
Mr. Chair, the amendment is going to be on page 1, line 18, after association, comma, strike the Virginia Magistrate System Coordinator, comma.
And
Just a second, is there a motion second for that? All in favor, signify by saying aye. Aye. All right.
Okay, thank you, Mr. Chairman. There may be an addition of another stakeholder and if so, I'll present it at full committee, Mr. Chairman, with your forbearance, sir. So, as amended, what this will do is direct these folks to develop a comprehensive model for the use of alternate transportation providers to provide the safe and efficient transportation of these individuals involved in emergency custody or involuntary admission process. As you know, Mr. Chairman, or you may well know some of the members, we had a pilot program using the Mount Rogers Community Service Port all the way down to the furthest little tip in Southwest Virginia that was quite successful. It had over 700 transports during that time period, and half of those were transported by an alternate transportation provider, someone not in a police car, handcuffed, with the challenges associated thereof, but instead someone dressed in khakis with a polo shirt and an unmarked vehicle that is trained to deal with sort of emergent mental health issues. And with that pilot program, they had 0 elopements, folks just sort of leaving in 100% safety. So it's very encouraging, and I wanted to roll that out statewide, but I ran into realize that we need to further address the safety issues, figure out which folks really do qualify for using this alternate model, and then also the cost to the Commonwealth. So my alternate plan, short of rolling out, let's go do it statewide, is to get these stakeholders together, let them fully vet this and discuss this, and come up with a plan by October 1 of 2017 with the legislation that I hope we can move forward with next year. That's basically what the bill does, Mr. Chairman. I'd be happy to answer any questions. I know of no opposition.
Anybody have any questions for Pedro? Let's make sure there's any public. You and I heard this all before. Delegate, go ahead.
Thank you, Mr. Chairman. This just creates the model, not the program, so no fiscal impact is needed. Delegate, Mr. Chairman, Delegate Hodge, that's exactly correct, sir. Applaud you for bringing this bill. Thank you.
Anybody else have any questions? Remember, the public like to be heard. This was something that came out of the DC Commission. I'll entertain a motion. Motion is to report the bill as amended. All in favor signify by saying aye. Aye. All right. Delegate Robinson, 1919.
Thank you, Mr. Chairman.
Yes, sir. Thank you, Delegate Garrett.
Can I say something here? Mr.
You
Chairman?
may, whenever you're comfortable.
House Bill 1919 deals with assisted living facilities to change the fee cap on violations. It just changes, it doesn't change the $10,000 fee for violations, but it does change the time period. Right now, it's at 24 months. We want to shrink that down to 12. This was brought to my attention, and Senator Sturtevant also has the companion bill in the Senate by a constituent whose mother had suffered through a lot of physical trauma in a care or assisted living facility, and many of you may have received emails from her. She has taken several routes to get the problem fixed, including a letter to the governor, which I have, and just was very frustrated by the process. Assisted living facilities are required to have an inspection at least annually, and site visits for every complaint filed by members of the community. Making the cap apply to the yearly inspection makes the code more consistent with the required inspections and would properly find assisted living facilities that are found in serious violations. Many of them are top-notch. They take great care of the residents, but for those who fail to to do what they're supposed to do. For the individual care plan, our state regulations, we need to change this and have these stricter penalties. Right now, the way it's worded, if they reach their cap in that first year inspection, then the second year when they get inspected, they've already reached their cap, so then they're basically no violation. Also, when they go into consent agreements and compliance plans with the Department of Social Services, a lot of times those penalties and fines are reduced because they've got good faith that things are going to be fixed. So pretty much what we're just trying to do is condense down the time, same violation as far as fee goes, and we want the bad players to fix the problems and take better care of the residents.
So what this would do is instead of having 10,000 every 2 years, you could have up to 10,000 every 1 year.
Correct.
Of available. Okay. Any member of the panel have any questions for the patron? Any member of the public like to be heard? Are you aware of any opposition that just may not be here?
They discussed it with me and wanted us to possibly change the time frame to 18 months, but we feel that 12 months is really more appropriate since that's the time of the inspection.
Did you say grr to them? You did? All right. All right.
No, they were very nice.
Sorry. All right, motion's made to report and seconded. All in favor, signify by saying aye.
Aye.
Okay, so I'd ask staff, how many bills do we have left? 12. And how many Thursday mornings do we have left? All right, so what we're going to do then is next Thursday, we're going to do the same thing, try to get done by 11:30. If we can get done, we can avoid the next Tuesday night meeting. If not, that's our safety valve in case we can't. Thanks, everybody.